Real Clinicians, and welcome to this special presentation. I'm really happy to be joined today by Dr. Michael Lewis, Director of Foundation of Endodontics and faculty at the Hackensack Medical Center and in private practice at Teaneck, New Jersey. Dr. Michael Lewis, thank you so much for joining me.
Thanks for having me, Alan.
Dr. Lewis, you and I have talked about this topic many times before. It's really an important topic, and you have an excellent presentation ready for us on maxillary sinusitis of endodontic origin, a call to action. Now, I know you're very passionate about this topic, and you really should be, because I think it's way underappreciated in the field. And I agree with you completely, obviously. But can you tell our audience what prompted your interest first on this particular topic?
So the interest began actually with my wife's medical and dental history. My wife and I had been gotten married, and she was really suffering from periodic episodes of acute sinus infection that she really, it would come periodically, off sometimes with a change in season, sometimes when she got a cold, and all of a sudden it would go into this terrible sinus infection that she sought treatment for from her medical physician, and she would be treated with courses of antibiotic and it would go away. And this was a recurring issue that really came about, on a fairly regular basis, and it was really, really terribly debilitating. As I had gone through my endodontic training, we diagnosed her with previously unrecognized chronic dental infection from the upper molars, and tooth number 2 and 14 had been previously treated, really not terribly symptomatic, but on exam we noticed that there was some tenderness on the teeth, and there was in the mucobuccal fold. And when we exposed a radiograph, we saw that there was a lesion that could be appreciated. And so we treated those teeth, and all of a sudden her dental infection, once the underlying dental infection was eradicated, those recurrent sinus infections really ceased to be. And it really began to spark an interest in me in terms of saying, well, wow, if this sinus infection is really tooth related, how can we kind of diagnose these things while they're in the quiet phase and kind of solve a problem that really wasn't connected in the patient's mind to her teeth? And so I really began to take an interest in this area and start to study it more closely.
Yeah, I mean, it does make a lot of sense. Obviously, the maxillary sinus and the roots of the maxillary teeth have a very close anatomical relationship. We all know we have 4 pairs of paranasal sinuses, and the fact that you have this close relationship between the apices of the teeth can mean that infections of various kinds of origin, but primarily generated around teeth, can end up, at least in the maxillary sinus, which is closest to this, and it could cause a lot of these issues. But how common is maxillary sinus of dental origin from your search of the literature?
So the first report in the literature was actually from a gentleman by the name of Doku. He reported that it was about 10%. And what's really interesting is that with the advent of the cone beam CT scan, we're starting to recognize more and more that maxillary sinusitis is frequently of dental origin. And this percentages of cases that are actually ascribed to dental origin in the literature is getting higher and higher and higher. That 10% number that was first presented has really been revised upwards. Reports in the literature are 40% of chronic maxillary sinusitis is actually attributed to teeth. That's a really high number. And if you narrow it even more closely to what does the sinusitis present on one side, well, if it's presenting on one side, it can be upwards of roughly three quarters of the cases can be attributed to dental origin, not just these other causes that were more frequently attributed to in the past, such as allergies or a deviated septum. And so, this is there's really a very pertinent information for endodontists and for dentists in general to appreciate that our patients' maxillary sinus problems, whether it's acute or chronic, are really dentally related. And it's important to understand that because it really changes the way you approach treatment.
Mhm. And Michael, also in terms of, well, I mean, it would make quite a bit of sense for unilateral maxillary sinusitis to be of dental origin, because oftentimes, then you have a situation with a given tooth. Where it's bilateral, then I think from what I'm gathering, you're saying is probably mostly non-dental related, or unless the patient is really unlucky and they're having two problems simultaneously on their teeth, both on the right and left side of the maxilla, correct?
Yeah, that's, it's more, if it's presenting unilaterally, it's more likely to be dentally related. But I've had a bunch of cases where, patient had uh, infections on both sides and they were both dental in origin. So I can't tell you that I haven't seen cases of bilateral maxillary sinusitis. They were also dentally related. How frequent that is, I think more studies needed on the subject. It's an interesting question. I would like to see some answers to that, but
Yeah, because I mean, I'm sorry to interrupt, but from an anatomical point of view, you cannot have maxillary sinusitis that bilaterally that's caused from a dental infection only on one side.
that is correct. It would have
Right.
to be two separate independent problems for it to be present.
Terrific. So that brings up one of the very common causes of chronic problems associated with maxillary teeth, specifically maxillary first molar, and very often also with the maxillary second molar. And that is that annoying little canal we call the MB2, the mesiobuccal 2, which is very thin and small. It's present histologically in 92% of the cases, but it is oftentimes missed because of the requirement of really high magnification. What are your views about the role of MB2 in, or rather the role of missed MB2s in these types of chronic infections?
Well, in my own practice, the missed MB2, when a tooth has undergone root canal therapy previously, when they present with a dental infection on that tooth, more oftentimes than not, it's due to the fact that the previous practitioner had gone in and gotten one of the canals in the mesiobuccal root, but that second canal was not really fully debrided properly, whether it's in a lateral dimension along the working width, or if they didn't get down all the way. The bottom line is that MB2 was not properly cleaned out and disinfected and obturated, and that is really the a high source of failure that in initial treatment. That MB2, as you mentioned, is present in 90% of the time, and one of the things I always like to discuss with general dentists is, hey, if you're finding it 10–20% of the time, that really means you're missing it more than 50% of the time. And there really has to be a higher standard of capture of the MB2. If you're not identifying it, 50% of the time, you're probably not getting it. It's present and you're probably missing it. And the consequences of missing it, we're starting to appreciate more and more, is that that underlying infection will eventually, over time, it has a high likelihood of causing maxillary sinusitis. And what's really interesting is that when you have I always describe to patients that the roots of the upper molars, the relationship with the sinus can oftentimes be like a pencil being pressed up against a balloon. It's really intimate. And when you have that intimate anatomical relationship with the sinus, oftentimes when you have a lesion presenting at the tip of the root, it'll spread directly into the sinus. And what that will translate to is that the patient's symptoms will primarily be sinus related, and clinical symptoms of pain in the tooth will largely be absent. And that makes sense because the lesion is not really going to be spreading into the bone or really affecting the ligament so much. It'll really be pouring directly into the sinus, and it won't manifest as a terribly symptomatic tooth. The signs will be there, though, but they'll be more subtle.
Yeah, you're absolutely right. I mean, of course, I hope your analogy of a pencil against a balloon means the eraser end of the pencil, not the sharper tip. But it does. You're absolutely right. That is finding the MB2, as you mentioned, the capture rate is a significant thing to consider because finding MB2 is quite a skill, and it can be gained. It requires lots of practice, but I think primarily it requires the understanding that it is there. And then finding that right balance where you can find it without really destroying too much tooth structure, and then still preserving the tooth in the long run. it has to do with having high magnification and high illumination, and then knowing where to go, which you can really gain by doing a lot of practice on extracted teeth, which is something I certainly recommend to people who really want to do maxillary molars. But if you somehow are not finding that, then you are in trouble, as Dr. Michael Lewis actually just explained. Michael, actually, I had a case myself, which was just over the past week, of an endo that was done by one of my referring dentists, who is a great dentist, a general dentist who uses a microscope and does great endodontic therapy, and had done this maxillary first molar, and the root was really curved. He did a beautiful job getting around the curvature, and however, it does have has a chronic lesion associated with it. The patient's had a history of unilateral sinusitis, and taking a radiograph, even though the apex of the root is not very close to the sinus, this patient has had complaints of occasional nosebleeds and also a history of sinusitis, which the otolaryngologist in this case actually thought is of dental origin, so wanted to have it checked by a specialist. So it is. I haven't done this. We're probably going to go ahead and do a surgery on it, and I'll probably bring that case and probably discuss it a little bit later. But it does appear on the radiograph that it does have a lesion, and also the CBCT was very helpful in finding that, which kind of leads us to your case that you're going to discuss next, where you do kind of put together all of this information to diagnose the next case. So why don't you go ahead and present your case, please?
Okay, so this is actually a 49-year-old patient that was referred to me for retreatment of root canal tooth number 15. His medical history was relatively unremarkable, and when we took a pre-op image, we can actually see that in this case, the mesial-buccal 2 canal was found. You can see that second canal is partially obturated, and if you look at the associated preoperative cone beam CT scan that on the right-hand side, you can appreciate that there's an apical lesion developing around that mesial-buccal root, and you can actually see lots of associated soft tissue thickening in the maxillary sinus. And here you can really drive home the anatomy of the case, that how intimately that mesial-buccal root is associated with the floor of the sinus. And so we advised retreatment. He actually had some palpation sensitivity on this tooth. The flare-ups were actually managed periodically over those years with antibiotics. One of the things that I like to do when I get a patient who presents with possible sinus symptoms is this sinonasal outcome test. This is actually a really relevant tool for the endodontist in terms of measuring the effectiveness of dealing with resolution of maxillary sinusitis. And what this test measures is it quantifies how severe the patient's sinonasal symptoms are. And if you look at this abstract that we have up here, the article really that's discussed in the Annals of Allergy and Asthma and Immunology in 2013 really discusses how much money and time is spent on dealing with chronic rhinosinusitis, which is really postnasal drip. And it talks about how much money is spent. It's close to $8.5 billion a year is spent on this condition. And a lot of it is dentally related. As we see in this case over here, this is very clearly dental in origin. So we took a preoperative sinonasal outcome test, and the baseline score is 55, which is actually quite high. It measures just a series of 22 sinonasal symptoms, and when you get a score of 55, that's one of the highest I've had. The patient reported that his voice would sound kind of nasally, and he would oftentimes have to he would get lots of discharge through his nose, and so he related all these symptoms that really highlighted how significant his sinonasal symptoms were. What was interesting was that when he initially came in, he didn't really report this, and that's the point I really want to drive home, is that a lot of our patients come in with significant underlying sinonasal symptoms that are not really reported, either because the patient is not aware of it, or they think that it's not really relevant to our discipline. And it's important to take a very probing history, and this sinonasal outcome test really gives us a baseline on all these questions and gives us an understanding of how much the patient is suffering, even if they're not reporting it. And it's our job as clinicians to really probe and ask questions about this thing. And if you do that, I think you'll see, as I've seen, that a lot of our patients have these associated underlying symptoms that are not really being appreciated or recognized when they're in the quiet phase. And it's important to measure that, and as we'll see moving forward, the effectiveness of simple endodontic therapy can be very profound in terms of relieving a lot of these symptoms that our patients are coming in with. So here we actually see some images of the treatment. The image on the left is the tooth as it was accessed. We can actually see a lot of black pigmentation of the tooth. That's indicative of there's also a foul odor when we opened up the tooth, indicating a lot of bacterial presence inside these canals. The image to the center of the screen is after the canals have been completely debrided. You'll see some glistening in the canals. There was actually some fluid and some exudate that was kind of weeping up into the canal. And as is typical in cases like this, what I like to do is to leave an intracanal medicament, in this case calcium hydroxide, and we closed up the tooth with a temporary filling, and we brought the patient back 30 days later. And here we can actually see, moving over to the next slide, we can actually see the obturation visit 30 days later. We went in, you can actually see the mesial-buccal 2 canals now fully cleaned out and obturated down to the root terminus. And at that point, as is typical, I like to take a post-op cone beam CT. And the reason for that is, Alan, as you know, there can be all kinds of very unusual and interesting anatomy. That have had 3 cases of mesial-buccal canals, and I don't want to miss any of them. And the cone beam CT taken post-operatively really kind of tells us what's going on inside the tooth and making sure that we didn't miss anything. And here, when we look at the cone beam CT taken, we can actually see remarkable resolution of that sinus floor thickening, because the healing process is taking place. Once the bacteria are eradicated, the reactive lesion that's present will start to diminish, and you'll start to get healing of the soft tissue and regeneration of the normal tissues that are found. When I took a post-op sinonasal outcome test, this score decreased from a 55 to a 32. And we brought the patient back at 6-month recall, and we took a follow-up scan, and here we see the sinus inflammation has gone down to completely 0. The reason why we took a cone beam CT at this point was actually the patient had never gotten the tooth restored, and I wanted to make sure there was no associated redevelopment of pathology. He had been sitting in cavit. We had removed the cavit. Everything looked pristine underneath, which was, you know, sometimes you can really get leakage, but in this case, we wanted to just verify that everything was normal. And he took another post-op sinonasal outcome test, and here's what's really interesting. The patient had really denied seeing an ENT when he first came to me. He didn't retract that at the 2nd visit, but at the 3rd visit, he's like, "Doc, oh my gosh, you know, I actually have seen an ENT, and I've been dealing with these sinonasal symptoms for 20 years, and until you brought it into my attention, I've really been suffering, and I'm feeling better than I have in a whole decade." And the patient did admit at that point that he had been treated with Flonase, and he did admit at that point he had treated with a sinus lavage, and neither one worked. And it really drives home the point that these patients are oftentimes being treated rather unsuccessfully with medical interventions such as antibiotics and Flonase and sinus lavage, and they're not effective in the long run, even though they can bring associated relief of the symptoms short term. You know, in my wife's case, she felt great after a course of antibiotics. Did it resolve the underlying infection? Absolutely not. And it's going to recur unless the underlying dental infection is addressed. And it's important for us as clinicians to recognize these symptoms when they're in the subacute phase, so that our patients don't have to deal with this acute sinus infection. You know, oftentimes I see patients, and when I see clear endodontic pathology in these upper maxillary molars, and once they're treated with a course of antibiotics, the sinus inflammation will go down. It will temporarily resolve that reactive lesion in the sinus as the the extraoral bacteria are eliminated, but the source of the bacteria, which is inside the tooth, the antibiotics won't be delivered there because there's no blood flow. And so, of course, the infection will reemerge after a period of time. And in many ways, treating these patients with antibiotics does a disservice to the patient because it number one, it really makes it more difficult for the dental clinician to recognize maxillary sinusitis of dental origin when a patient has been treated with antibiotics, because you can't read the patterns of inflammation in the sinus when they're gone. And that's a really important point I want to drive home, that treating these cases with antibiotics is not consistent with the position of the American Association of Endodontists. It can actually develop a more resistant biome to when you treat with antibiotics, the remaining bacteria will become more resistant. And it also really prevents the patient from seeking the dental treatment that is necessary to resolve the underlying infection. And no clinician should be kind of fooled into thinking that leaving a patient satisfied with a short-term course of antibiotics is a definitive response to this pathology.
Yeah, I think you brought up some really good important points that I just want to quickly mention here too. So obviously then you did not give antibiotics to this patient. Calcium hydroxide therapy was the right path to go. There is no reason for systemic antibiotics in this case post-operatively or mid-operatively, correct?
Correct, absolutely.
Yeah.
I actually really don't, the only indications for antibiotic therapy are signs of a spreading infection, whether it's swelling or signs of fever. That would be a case when in an acute abscess where it would be appropriate to give antibiotics just to help the patient manage the acute symptoms. But when you're dealing with chronic symptoms, it's certainly not in keeping with the position of the AAE to prescribe antibiotics. And it seems like there might be a disconnect there between how different medical specialties approach and handle this case of maxillary sinusitis. If it is of dental origin or if it is of bacterial origin, you know, it has to be questioned and studied whether antibiotic therapy is appropriate in cases like this.
I think antibiotics have been used as a crutch for too long in the medical profession, and only now we're beginning to understand the negative consequences of using antibiotics in the way we have in the past, as we are beginning to understand the role of the natural biome that's present in the body and its important interaction with our overall physiology. I mean, did you know, Michael, that 95% of the research in antibiotics and microbiology as it relates to the biome has been published within the past 6 years? Isn't that amazing? So how little did we know before? We were just handing out antibiotics like candy to people. So
you know, it's amazing how fast the science is progressing.
yeah,
it's crazy.
This also brings up a very important point that I want to discuss, which relates to practitioners as well as patients as a whole. So here we had a case that had endodontic therapy, because oftentimes people say the endo failed, or the tooth failed, tooth infection, root canal therapy, and they associate these things with the procedure itself. Whereas the more important thing to understand is what is happening as an underlying cause and what causes persistence of disease post-treatment, and how in this case you basically demonstrated how when endodontic therapy can be done properly and correctly, that there is no reason for the endodontic therapy not to work and for there to be persistence of lesion. You know, one of the things that I always say, Michael, is people oftentimes think that root canal therapy is a commodity. It's like a shirt that you could buy from, I don't know, from a high-end store or an outlet. And it's the same shirt, but it's two different prices. But it's really not. It's a skill-based procedure, and understanding the foundational science behind achieving success is so critical in terms of achieving success, because it's not about radiographic look, as you saw in this particular case that you just showed. All 4 canals had been treated. There was persistence of infection, which had nothing to do with the fact that there were root canal fills on the x-ray, but that there was inadequate disinfection inside the tooth. So I think that's an important point to keep in mind as well. And you demonstrated beautifully in this case how when endodontics has been done properly and correctly, when all the canals have been found and all the source has been eradicated by proper disinfection and adequate apical diameters at the end of the root to clean the tooth out, it could be it could have excellent results. Of course, we also rely on our patients, and we also demonstrate in this case that this is a cooperation. If people don't follow up with the recommended treatment, that they can have problems down the line.
Absolutely.
So Michael, one last thing I want to talk about before we take a break is the sinonasal outcome test that you mentioned. It's obviously, I love the innuendo there with the SNOT, the sinonasal outcome test. But it's a very important thing. Also, you've been kind enough to share with our viewers the little form that you've prepared yourself for this type of questions that can be asked. And I'm going to have a link for the form that you've put together for us below this video that you can download. And I think it would be very informative to have your patients fill this out so you can get an understanding as to whether they have sinusitis and versus unilateral and how it's affecting their lives. So you can give them an objective test for a score that you could then have a comparison with. So Michael, do you want to add anything to that test?
When you start to administer this test and collect this data beforehand, I think the dental community it's changed the way that I perceive things, and I think that by sharing this test, I think that other clinicians will be able to reproduce the things that I'm finding, and my hope is that it will become more appreciated within the dental community just how common and how profound the effect these chronic apical lesions on these upper teeth, what kind of an effect it has on the patient's overall well-being. And just even though the symptoms are subtle and they are oftentimes in the patient's mind not worthy of complaint, once they resolve and the patient is asked to reflect back upon it, they really report a tremendous satisfaction, and it resolves a complaint that they didn't even know they had. I'm hoping that it will spur a discussion between dental clinicians and maybe even between the umbrella organizations of the ADA or the American Dental Association, or perhaps the American Association of Endodontists with the Academy of Otolaryngology. Because if you look in the ENT literature, oftentimes the sequence of treatment is, well, first try medical intervention, whether it's antibiotics, nasal sprays, or corticosteroids such as Flonase, and if that doesn't work, let's go into and relieve the fluid in the sinus by enlarging the maxillary ostium, which is actually an opening that leads into the middle meatus, which is part of the nasal passages, and then back down the throat. And when they do these types of surgeries, it will oftentimes relieve the patient's symptoms of sinus pressure, but it'll oftentimes be associated with post-nasal drip as that fluid is dripping to the back of the throat. And oftentimes that's really not a very elegant solution.
Yeah, that's basically not addressing the source of the problem. I think from what I gathered, then having proper diagnostics, whether it's the use of the SNOT test as well as your basic clinical diagnostics with the aid of a CBCT to find out better what kind of a picture you're dealing with, and then quality treatment, not just endodontic therapy, but quality endodontic therapy is critical in order to get proper success and resolution to a systemic problem that has got local sources inside the tooth. So Michael, it's been really enlightening and wonderful. Let's come back, let's take a quick break and come back and share another case with our viewers.